And the second speaker is Dr. Chuang Shao-Yuan. And Dr. Chuang got his PhD from the Institute of Public Health, Master National Yangming University in Taiwan. And he is currently an investigator at the Institute of Population Health Science, NHRI in Taiwan. And he is also a joint associate professor at the Institute of Public Health, National Yangming Jiao Tong University in Taiwan. The specialty of Dr. Zhuang is mainly on cardiovascular and aging epidemiology and hemodynamic and connective function. And today, Dr. Zhuang is going to talk about the association of body weight and weight change for mortality risk, cardiometabolic disorders, controls, and the physical mental function decline in older adult population. So let's welcome Dr. Zhuang.
Okay, thank you, moderators introduction, and this is a great honor to have a speech to share my study work. My talk is about association between body weight and weight change and the mortality and cardiovascular disease control and the physical and mental function decline in elderly population. This issue is be investigated 30 years ago by Dr. Fischer and Dr. Mary Ann Johnson, and they reported a review study show that low body weight and rapid intention weight loss are highly predictive of mortality and morbidity in the elderly population. And this study suggests that healthcare professors must monitor body weight in elderly population and carefully evaluate any cases of rapid and or unintentional weight loss to prevent the future deterioration of the health status. And during 30 years, many studies had been continued to study this issue. So this study showed that there is a U-shape. There is a U-shape between body weight change and weight loss, and a U-shape between body change and mortality. And we can find that the elderly has weight loss. Elderly with higher weight loss had higher risk of mortality, and elderly with weight increasing had higher mortality. And this relationship is independent and initiate body weight BMI, and we also find that there is a negative association between initiate BMI and mortality, future mortality. And this is another further study show that small weight loss or small weight gain is not associated with mortality risk, but large weight loss is negative. Large weight loss is negative associated the mortality, and and we also find that large weight loss in the elderly with low BMI had higher risk, but large weight gain in higher BMI elderly has higher risk, mortality risk. Okay. And the further study with the repeat body weight measure, and this study showed that weight continue to lose by elderly. And this study also showed that identify the elderly with into weight loss group and weight stable and weight stable and unstable group, and we can find that the elderly, the subject with weight loss and weight unstably had higher risk for mortality. And the further study also identified the elderly with weight loss and weight cycling has higher mortality and and their mobility, mobile disability. Okay, so recently a systematic review study and meta-analysis report that the elderly with classify their body change with weight loss and weight gain or weight fluctuation. These three groups associate higher mortality risk. However, those per study has a few Asia population. So I will introduce several recently years several study in Asia population. This is from China population, and we can find that there is a U-shaped association between weight change and mortality. And those elderly with weight loss or weight gain, they have very extreme higher risk for mortality, all-cause mortality and all CVD mortality. Another study, this is Taiwan was conducted in Taiwan population and find that the elderly with higher weight change, weight gain has lowest mortality, but the weight loss in elderly at highest mortality. Another study showed is from Korea. This study is with repeat major body weight, and it find that the elderly with obesity, the orange line is obesity, more than BMI with higher than 28, and find that the obesity elderly has lowest mortality, and the elderly with low normal weight has highest mortality. Okay, and this is from the Japan study. This study with repeat major and to investigate the weight loss or weight change, association between weight loss or weight change and mortality in 3 intervals. And this study find that if elderly with weight loss more than 5% has highest mortality risk in short term, middle term, and long term. So we have from this studies we have find that weight change associated with high mortality risk is including weight loss or weight gain and weight fluctuation. And we also find that large weight loss associated higher mortality in the elderly with lower BMI, and the large weight gain associated with higher mortality in elderly with higher BMI. However, in Asia population, and we can find the study is not inconsistent. In China, we can find that a U-shape is higher weight loss or weight gain is associated higher mortality. And in Taiwanese population, and we find that a negative chain association between weight loss and mortality. And we find that weight gain is had the lowest mortality. And in Korea, we also find that the higher BMI has lowest mortality. In Japanese population, and we can find that weight loss had higher significant mortality. So, so we were to there are some question about body weight or body change and mortality to need to answer. One is the gender difference, and another is we have no weight loss or weight gain is associated with the metabolic components or metabolic profile distribution. Another in elderly population, another issue is weight loss or weight gain may associate physical function or mental function decline. So in this study, we will to investigate the body mass index and the mortality change for mortality risk, cardiovascular disease control, and the physical and all mental function decline in elderly population. So this is our 4 specific aims. We want to investigate baseline BMI and the mortality, or another is a weight change and mortality, and the weight change and the metabolic disorder control, and the weight change and the physical and mental function decline. So we use the host study. Host study was be introduced by another Dr. Su-Jun Chen. And okay, so include 7 study sites in Taiwan, and we use the baseline and second wave and to follow and to identify the survival status. Okay. So we define the BMI is body weight divided by the square of body height, and we identify this is a hypertension definition, and this is a high LDL cholesterol definition and diabetes definition. Okay. Okay. This is BMI obesity definition by our government clinical criteria, and underweight is BMI less than 18.5, and this is the normal range, and the obesity overweight is between 20 BMI with 24 to 27, and obesity 1 is BMI between 27 to 30, and obesity 2 is BMI more than 30. And physical function, we use the 4-meter walking space with regular pace, and another is hand grips. And the mental function, we use the MMSE to measure their cognitive mental function. Okay. So this is our result about association between baseline BMI and mortality. And we use the national death registry to identify their survival status, include all-cause mortality, CV mortality, and other cause cancer mortality. Okay, this is a population profile, and the average age is 67, and the average BMI is 24.5. Okay, and the hypertension is about 48, and the diabetes is 26, and the high hyperdyslipidemia is 45. Okay, so we follow 10 years, and we can find that this is the CVD mortality, this is the cancer mortality, this is all-cause mortality, and during the 10 years, and there was more than 1,600 deaths in men, and about 200 deaths in women. Okay. And this is the association between baseline body mass index and the mortality, and this is men, and we can find that the elderly with underweight has highest all-cause mortality, and those men elderly with obesity 1 or obesity 2 has the lowest mortality. But in women, we can find that different association. And in women, there is a U-shaped association between baseline body weight, body mass index, and the all-cause mortality. And we can find that in women, those women in obesity 2 had the highest mortality. The second is the elderly woman with underweight. Okay. And we try to control potential mortality, potential confounder, and we can find that in model 1 and model 2, we adjust the cardiovascular comorbidity, but such as hypertension, diabetes, dyslipidemia, or smoking and drinking. And we also find that in men, those underweight had significant highest all-cause mortality. And if we change to this is compared to the normal weight. If we change our reference to the obesity 1 group is the lowest all-cause mortality. We also find that the elderly with underweight has highest significant all-cause mortality. In women, we can find that even we control age, and we still find that the elderly with obesity 2, with BMI more than 30, had highest mortality. But we control the CVD disease risk factor, and the association is no longer significant. So maybe we can explain that the obesity may associate with many CVD factor risk factor, and then we control them, so the association between high BMI and mortality is disappeared. Okay. Then, because we know that in elderly may have heart disease, some elderly with fatal disease history. So we exclude heart disease, stroke, and the cancer patient history, and we can find that the association is similar. And in this population, we find that the elderly with low underweight has extremely higher than other population had a higher risk for all-cause mortality. And the U-shape in between BMI and the all-cause mortality in women also significant. Okay. So we also control the potential risk factor, and we can find that this is men, and we find that all elderly with low underweight had significantly higher risk for mortality. Okay, so another we change to the reference in those elderly men with obesity 1 as a reference, and we can find that the elderly with low underweight has significantly higher mortality, and those with obesity 2, their BMI is more than 30, also have a significant all-cause mortality. However, in women, we just find that BMI is not associated with the all-cause mortality when we control the diabetes, hypertension, and the dyslipidemia. Okay. So in section 1, we have about the association between baseline BMI and the mortality. We can find that among elderly men, those with BMI had between obesity 1, BMI between 37 and 27 and 30 had the lowest all-cause mortality, and compared to those with normal weight and the underweight, older men had higher significant higher all-cause mortality. Even if we exclude fatal disease population, the older men with underweight and obesity 2 had a significant higher mortality compared to the obesity 1 in women. But in older women, the overweight had the lowest all-cause mortality. Okay. So another issue is we want to investigate the association between weight change and mortality. This is our design. We use the baseline and the second wave body weight to calculate their weight change. And we follow their by national death registry for survival status, and we follow about more than 5 years. Okay, and we have during 5 years, and we have more than 200 deaths in men, and more than 60 deaths in women. Okay. And this is our profile about the second wave, and all the average of age in this population is more than 72 years old. Okay, their body weight, body mass index is in average is 24. Okay, and the population, the hypertension prevalence is 54, and the diabetes population is 25, and the hyperdyslipidemia prevalence is 43. Okay, and the association between body weight change and mortality, and we can find that this is the man and this is the woman, and we can find that a similar association, and there is a U-shape association between body weight and change and mortality. We can find that if the elderly change with less than weight loss than 10%, there has the highest mortality in men and women. Another, we also find that the elderly weight gain at more than 10% also have higher risk mortality. Then we control this model 1, we control age, and model 2 we control CVD effects, risk factor such as hypertension, diabetes, dyslipidemia, smoking, and drinking. And we find that in elderly men and weight change stable between negative 5% and positive 5%, and this is a reference group, and we can find that if elderly men and their weight loss between more than 5% they have a higher significant mortality, and if they weight gain more than 10%, also have higher significant mortality. Okay, and the model 3 we further control the physical function, and the weight gain the weight gain more than 10%. The significance is not longer. But in women, we find that weight change is not significant higher or lower compared to the weight stables. Okay. And we further exclude potential high-risk population, and we find that there is a U-shape between weight change and the mortality, all-cause mortality in men. And we also find that those elderly with weight loss more than 10% has highest all-cause mortality. And the second is the weight gain more than 10%. And in women, and we find that elderly with weight loss more than 10% has highest mortality. But we did not find any event in those elderly with more than weight gain more than 10%. Okay. So we control others potential risk factor. We can see a similar result between the weight loss and the mortality in men. And we also find that the elderly with weight loss more than 5%, between 5% to 10%, or more than 10%, weight loss more than 10% has higher risk for mortality. And weight gain more than 10% has higher risk of mortality. Okay. And in women, we can find that the elderly with weight loss more than 10% has higher mortality. Okay. So another third issue is we not have knowledge. Weight change has associated with the hypertension, diabetes, insulin, or dyslipidemia, or diabetes, and those are the stroke, heart disease, and renal disease, and risk factor. So we want to know that weight gain or weight loss, how to influence the metabolic risk factor in elderly. And this table shows that, and we can find that this is weight gain, this is weight loss. This another is waist circumference, and we can find that if weight gain and positive associate systolic blood pressure, diastolic blood pressure, and mean blood pressure, it means that if you weight gain, the higher weight gain and the higher blood pressure, and the triglyceride, and lower HDL-C and non-HDL-C. Okay, and we further to identify how weight change to influence the blood pressure control. And okay, this is if we this is a man and this is a woman. In men and the weight loss and their control, their blood pressure well controlled, preference is increased. But weight gain, if weight gain, their control rate is decreased. This is a woman. This is a woman. We can also find a similar, but the influence weight gain for the blood pressure control more strong in women. Okay, and this is a weight change for the glucose control, and we can find that if weight gain, the glucose control rate is decrease in men and in women. Okay. And another, this is the weight change and the association between weight change and the dyslipidemia and LDL control. And we can find that the weight loss, the LDL control is increased. Well control is increased in both men and women. Okay. Another, we want to know that how weight change is weight change associated with physical function and cognitive function decline. Okay. So this is weight change and walking speed, and we can find weight gain. Their walking speed is decline, and this is man and this is a woman. But in some women, the weight loss also their walking speed is decline. Okay, and this is the association between weight change and hand grips change, and we find that the weight loss their hand grip was decrease, and this is a stable group. This is more than the weight loss between 5 and 6%, 5 and 10%. Okay, and so we can find that if you weight gain, the hand grips almost not almost compared to the stable group in weight the weight gain in weight gain groups, and this is the association between weight change and the MMSE change, and we can this group gray bar is the stable group, and the others is weight gain group. This is weight loss group. Okay. So we have a summary about our information. In men, and the weight loss is higher mortality risk and better blood pressure control and LDL control, and worse hand grips and cognitive function. If weight gain and higher mortality risk and worse blood pressure control, glucose control, and lipid control, and worse walking speed, and neutral in hand grip and cognitive function decline. In women, weight loss also increase the mortality risk, but weight gain not associated with mortality risk in women. Okay, so and in women, weight gain also worse glucose and hypertension control, and worse walking speed. Okay, so this is the profile about the BMI and the BMI change for the all-cause mortality and body cardiovascular risk factor control and cognitive function decline and the physical function decline. Okay, thank you.
Thanks, Dr. Zhang.